about the single antiplatelet therapy strategy in ACS. And as you know, and let me take a look about the history of PCI in the 1929 and enforcement and opening a new sky to the PCI. And so in 1977, and Jim Gonzig and started the PDCA times. So, and the first stent is implanted in 1986, and in 2003, the DS, the first DS implanted in the first mean, and 20 years later, and we back come to the PDCA again, but this time we're using the DCB to treat the coronary artery lesions. And as you know, and because bleeding after the PCI is major problems, especially because of the severe bleeding occurs in 10 to 15% of patients, high bleeding risk patients, and during the first year. So, and you don't choose, and just mentioned by Professor John has to, and especially in the Eastern Asian, we need to tailor the precision of medicine. And so during the after the PCI and especially after the implantation of the DES, and we'll face to the high thrombosis instead. So we'll have to choose some antiplatelet or anticoagulation therapy. This is a timeline about the antiplatelet therapy. And first, you can see, and by Professor Grinzig, and probably successful coronary angioplasty, and he chose aspirin was used. Aspirin used for the pre-procedure, then followed by anticoagulant. And after that, and they choose several drugs and to anti the antiplatelet, like the aspirin and the ticagrelor and clopidogrel, and at present, and favored to choose ticagrelor in ACS patients. But in terms of the anticoagulant, we choose warfarin and the DOAC, and which means new auric like the river Sabran and such so on. So, but how to balance the ischemic thrombosis and the bleeding? So, take a lot of guidelines. These current guidelines on duration and do antiplatelet therapy after PCI, and for the patient with stable coronary artery disease, or the patient with acute coronary syndrome. And the first step is to evaluate the risk of bleeding. For the low risk bleeding, you can choose longer DAPT, DAP, dual antiplatelet therapy with clopidogrel in combination with aspirin or other and P2Y12 inhibitor. And for the patient with high risk bleeding, we choose de-escalation therapy strategy to treat the patient. And for patients with, especially for atrial fibrillation patients and going PCI, and Dr. Gao has talked about it, very, very serious. So we move to the next slide. The existing problems and challenges now is not at present time is hemorrhage, important factor influence prognosis of coronary artery disease. So the antiplatelet therapy reduce major adverse cardiovascular events while increasing bleeding risk. So using the dual antiplatelet therapy in high bleeding risk patients is challenge. So it's important to choose an antiplatelet therapy strategy with balanced bleeding and ischemic risk. So it's impossible to use single antiplatelet therapy in coronary artery disease because of the refinement in the DS technology and the potent P2Y12 inhibitor. So increased risk of bleeding, allergic to intolerance to aspirin, and refinements in stent technology and advent of potent P2Y12 receptor antagonists. So this result in the possibility to choose the single antibiotic approach, especially immediately after the implantation of DS or using the DCB. So these some trials about the P2Y12 receptor monotherapy after PCI, and like the global leaders, STOP2 and Twilight, but all of them, at the first month or half a year, they choose a dual antibiotic, just a short duration, and there's no study about the single antibiotic therapy immediately after the PCI or at the pre-procedure, they choose the single antibiotic therapy. So this our study in the safety and the effectiveness of ticagrelor early post-operating monotherapy antibiotic therapy in patients with PCI, and because some reasons, and the patient and the aspirin has been interrupted longer than 14 days during early post-operating 3 months after the second generation DES. And you can see follow-up at 6 months after PCI in the myocardial infarction. There's no difference in the dual antibiotic therapy group and versus aspirin interruption group. And like this one, in follow-up at 9 months after PCI, and there's no difference between the two groups. So this is the bulk bleeding, and aspirin interruption group has an increased risk of the bulk bleeding. And follow up at 9 months after PCI's bulk bleeding, you can see DAPT group is a high risk of in terms of the bleeding risk. So this indicates that ticagrelor early post-operating monotherapy, monoantibiotic therapy in patients with PCI was safe and effective. So our center tried to use single antibiotic therapy in high bleeding risk ACS patients. The defining high bleeding risk in patients in PCI is about major or minor factors. So as a reference to us, and our patient, at least one major bleeding factors, or at least the 2 minor bleeding factors. So database for single antibiotic patients, total about 61 patients. And the selection antibiotic drug in single antibiotic therapy, and of them, and about aspirin 180, clopidogrel and 60, ticagrelor 3, total 245 patients. But of them, there are only about 93 patients have the PCI, and so let's move to the next slide to talk about the PCI patients. The current different type of bleeding before SAPT, and composition of different type of bleeding, and the gastrointestinal bleeding is the main reason for choosing single bleed. It's account for 78%. Cerebral hemorrhage is about 11%, and outside hemorrhage 11%. So we choose which medicine should be chosen. Composition of single antibiotic drugs, and clopidogrel and aspirin accounts the most patients, and clopidogrel is the second. So with bleeding and gastrointestinal bleeding is just given the CAG, and this PCI, outside hemorrhage or PCI. All PCI patients is just accounts for the minors. Okay, let us see the database of PCI in single SAPT patients. All about is 93 patients have the PCI procedure. This is the risk factors for the patients with the PCI, and this male and female counts nearly half of them. So we can see the PCI, and the PCI can be divided into two groups, and the DS or DCB, or DS and DCB, and just 2% and success. So we can see, and among patients with the PCI, in the composition of different type of PCI, you can see aspirin, and in the DS and DCBs, it's count 37%, and DS and 37%. And for the DCB, clopidogrel is count 46% in the DCB group. Because the follow-up results of single antiplatelet therapy, patients of PCI at least after 1 year, number improved. The symptoms have been improved, and in about 26%, there's no change in 26%. General to still in general 2%. Other percent in his hospital by our disease, that only 1% death, and we lost the follow-up about 41%. So the discussion is that in patients with high risk of bleeding, dual antiplatelet therapy is unsuitable because of increasing bleeding risk. In high bleeding risk patients, PCI combined with single antiplatelet therapy was safe. Clinical outcome in PCI patients with single is favorable. For the future of single antiplatelet therapy in high bleeding risk patient is hopeful. And actually, there are several papers published by other professors, and as you know, in 2014, you can see a 51-year-old male present with acute inferior STEMI, and PCI was done to right coronary artery, and with everolimus eluting stent. So this patient received clopidogrel in the 300 milligram. After PCI, clopidogrel was replaced with ticagrelor 90 milligram twice daily. So the post-procedure 6 months follow-up has been uneventful. The case 2 is a 60-year-old female. And this patient used the clopidogrel and follow-up 15 months post-PCI. Remains well without any cardiac symptoms on medical therapy. So they still, in case 3, used the ticagrelor, and this patient, the follow-up has been uneventful. So now, and let me see one patient. This been a 58-year-old male. She has been for 5 years, exacerbated for hours. This patient has anemia history and the gastrointestinal bleeding history. So we just, this patient moved to our center, and trach intubation and pupil, and no heart sound, no pulse in other hospital, and has transferred to our hospital, and by support of ECMO. So diagnosed coronary artery malfunction, ECMO support, hypertension history. Now this is the EKG result when this patient has been moved to our hospital, into ventral fibrillation altogether all the time. So emergency treatment, ECMO support, and using the positive vascular active agents, and amiodarone, lidocaine, and other and give the defibrillation but failed. So you can see the angiography results occluded at the orifice of LAD. So and the support of ECMO and do the PCI for this patient. This is the final result. And recovered the flow to the LAD and circumflex and right coronary artery, and the support of IBP and ECMO. Then 3 hours later, after the ventral fibrillation, and give the this patient using the defibrillator recovered to the sinus rhythm. This 1 month later discharged. 2 months later follow-up, you can see there's a final result 10 months later follow-up. Okay, and this one published case report regarding this subject in Toothbrush, and this is the author. He said, to the best of their knowledge, this first study to report that the novel strategy of DCB only PCI followed by single antiplatelet therapy could be feasible. And in this patient, and all these patients has been using the DCB only and with single antiplatelet treatment for this patient. So, and this said is a single scientific experience of a novel concept. So the single or dual antiplatelet therapy after PCI, the review published on 2017, and at that time they used single antiplatelet therapy to treat the patient in the after PCI, but just to short the duration of DAPT. This new-minded trials and using the P2Y12 inhibitor monotherapy versus dual antiplatelet therapy in patients with acute coronary syndrome undergoing coronary stenting, and they plan to enroll the patient. They said maybe this study is the first study that is specifically designed to test SAPT versus DAPT immediately following PCI with DES in ACS patients. So maybe this trial will provide important insights on the efficacy and safety of withdrawing aspirin in the early phase of ACS. Our pilot study has proved that the single antiplatelet therapy strategy immediately following the DES implantation or the usage of DCB in patients at high bleeding risk is safe and effective. Even this study has the limitations of a small sample size. A single center retrospective for short periods with non-randomization, this novel concept should be paying more attention. The strategy may be confirmed by other RCT